So I will try to make this as simple as can be. It's always nice. I want to thank Dr. Fraser and also the CLL Canada group for having me come back again. It's been many years, and I see some familiar faces and some patients that I know as well. So it's truly a pleasure to come back and do this for all of you, really, really. I have the pleasure of talking about new drugs in the pipeline, and I'll try to make distinctions because I know that, again, I'm a New Yorker, so I understand that the U.S., what's approved in the U.S. may be a little different than what's approved here in Canada, and my Canadian colleagues will hopefully kick in, and then you can yell at me and tell me, no, it's not approved yet. But I have a little bit of knowledge of that. But hopefully we'll just really, I think there's some general themes that, here's my disclosures. I play with everybody. Just so you know. And I think that's really important. The industry sponsorship, of course, is what's moved these drugs forward, right? And so clinical trials, which I know is coming later to a discussion about clinical trials, but certainly this is how we move the field forward and bring, as we've just heard, chemotherapy has moved a little bit away, and so we have new targets, and that's where we get these drugs from the clinical trials. So for those of you who have participated, I thank you all. For those who haven't, it's always a consideration, and you should always ask your physicians what clinical trials might be available. And you've heard certain themes, and so I'm going to, hopefully, if you don't remember anything, there are just certain themes you should remember. And so one of them is that it's a journey. It is a chronic disease, and hopefully we'll have curative therapies. And for some people, we know that there's a group of you who never need treatment. I wish we had a blood test we can do and say you never need to come in again to see us because you're fine. We should focus on those folks and figure that out. But for those of you, sometimes you may only need one treatment, right? That might be all you need depending upon your age and other medical problems, and that's a possibility too. But for some of you, you're going to be on multiple treatments during your lifetime. So it is a journey. And we understand, it is mentally and physically a journey for some of you, no matter what stage you're at. And so just keep that in mind. And there's a lot of support, and you know that because you're here in the room, and there's a lot of groups who are here to support you and people who are here to support you. So we're going to start with, you heard about the diagnosis, you heard about initial treatment, and a little bit about relapse treatment and clinical trials. I'm going to reiterate, targeted therapies, you heard about this, really are, they target maybe a particular protein or receptor or a pathway in the CLL cells. It doesn't mean that targeted agents don't have any side effects. They just have less side effects than some of the stuff we showed you with chemoimmunotherapy. So hopefully there's less off-target, side effects to the good cells to reduce some of these toxicities. But it doesn't mean that novel agents or targeted therapies don't have any side effects, and many of you might know that if you're on some of these therapies. But they could block, particular chemicals or signals or proteins that allow the cancer cells to die. So since I'm going to be talking about a lot of that, that's what I just want to remember that background. Now, again, some of these drugs are not approved here in Canada. Pirtobrutinib is not yet approved, so I'm going to talk about it, although it is approved in the US, got approved in December of 2023, and I'll show you some of that data. And then, of course, CAR-T is not approved here in Canada, right? That's not either. And we'll talk a little bit about CAR-T as well. Okay. So you've heard this, and I think it's just important that you've heard this theme that depending upon where you started, it is individualized, right? So it's very hard if you say, oh, what have you gotten? What have you gotten? What did you get? It may be a very, very mix of discussion that you have amongst each other because people might have started their journey at different time points and different drugs were available. So if you started 20 years ago or 10 years ago, you might have still gotten chemoimmunotherapy, and then maybe you got a BTKi inhibitor or you got venetoclax and a combination. And so it really does depend on where you started on your journey when we talk about relapse. And it also depends on, did you have side effects from those therapies? Maybe that drug isn't really good for you, and so that may change the paradigm for you because maybe retreatment with a particular drug, again, may not be suitable because you had a particular side effect to that therapy. So these are all important concepts, and what your other medical problems do play a role. So everything my colleague said is absolutely true. So it really should be individualized. You really need to, it's your physician and team who are taking care of that have to really go through all of this with you when deciding upon treatment options, whether now or in the future. And absolutely, I absolutely agree that, everybody's focused on what treatment they may be getting now, but your physician and physician team are hopefully focused on what you might need down the road, that you're going to go from one treatment to another, and we're always thinking ahead. So we also do need to think ahead for you all as well, okay? I'm going to just introduce a concept just because it comes up a lot in the literature or when you talk to your doctors. And I don't mean to scare anybody, but when they talk about exposure, and this came up earlier with some of my colleagues' talks, you can get exposed to a drug, but that doesn't mean you've progressed on a drug. And so sometimes we can reuse those drugs again. So if maybe you got venetoclax, you did well, you got off of it, can you get that drug again down the line? Absolutely. That's a possibility. If you had a side effect to one drug, and this came up in the discussion about the different BTK inhibitors, if you have a side effect to one, doesn't mean you necessarily can't try another. It depends on the side effect, right? So if it's something severe, we might not want to do that. But if it's not severe, we might say, hey, you know what? We have a newer one. Let's try this, because maybe we could use it again, because you actually had a response to it, but your side effect wasn't bad. Maybe we could still use the class. So there's a notion of exposure versus true progressive disease. Okay, so if somebody really is progressing on an agent or shortly after an agent, we're going to be less willing to try that agent again, because it probably means it won't work for you. And that's where all these new drugs are going to be in the pipeline. So we're going to have fun talking about new agents. That means there's a lot of hope. So I want you guys to keep that in mind. There's a lot of hope because there's lots of new drugs coming down the pike. And so that's great. And so we're going to talk about these. I'm going to show some cartoons because I think that I'm going to try to make you understand the mechanisms of these drugs, because that's always a hard thing, particularly when there's so many drugs available. And when we talked about sequencing, or whoever mentioned some questions about sequencing, oh boy, is it going to be hard to figure this out, because now sequencing of these agents is becoming more and more challenging because, remember, part of this is how these drugs got approved and then how we move them up. And so it's going to be more of a challenge for us all to figure out what the right sequencing of these drugs are. But hopefully with time and more clinical trials, we'll be able to do that better. So we're going to talk about the non-covalent BTK inhibitors. So this is the Pirtobrutinib drug that got mentioned before. We're going to talk about BTK degraders. We're going to talk a little bit about CAR-T, other BCL2 inhibitors besides venetoclax, and we're going to talk about bispecific. See, a lot to do between now and lunch. All right, I'm going to skip on. So let's first start. We heard a lot about BTK inhibitors, and as the reason why somebody had mentioned just before with the question about, are companies interested in shortening the time period because they know, their drug has been used for so long and so they'll make more money. Well, part of this really had to do with the mechanism of the drug for the BTK inhibitors, right? So the BTK inhibitors really do block the signaling proliferation of your cancer cells, of the CLL cells, but it wasn't good at effectively eradicating the cell. So ibrutinib was the first to market. And so unfortunately, because of the mechanism of the drug, we knew that if we stopped people off a drug, their disease oftentimes would flare or come back quickly. And so that's why it was initially a chronic continuous therapy. Now, obviously, you've heard a lot about these combination trials with a BTK inhibitor and a BCL2 inhibitor to shorten that duration. So many of us are interested. Don't think, that we have industry who helps us, but don't think that the docs don't have your best interest at heart, because we do. We want people to get off drug if possible, although don't get me wrong, I think there are some people who can take a chronic therapy and do just fine, so it is individualized. I'm not going to say, that we shouldn't just abandon monotherapy with BTKs for everybody. But I do think our interest is in trying to get people off of drug, improve their quality of life, get them in deep remissions, get a break, and then they won't be resistant to therapy. So that's the BTK inhibitors in general. Think of the BTK inhibitors, now that's ibrutinib, so these are called covalent BTK inhibitors. That's ibrutinib, acalabrutinib, and zanubrutinib, right? Think of it like a light switch. And so that it helps the CLLs, as I said, survive. If you take an inhibitor, these drugs, if they're like the glue, they're going to prevent those CLL cells from switching off. So they're trying to inhibit the enzyme so that these CLL cells don't survive. What happens, unfortunately, over time for people who are on BTK inhibitors is they can develop resistance to these agents, okay? And so many people eventually, if they take the drug chronically, might start losing the sensitivity. So think of the light switch as changing a little bit. And so this is where non-covalent BTK inhibitors come in, because they don't mind if the cell changes a little bit. They can really bind to the light switch and prevent that. And so this is where drugs like Pirtobrutinib are coming into play, because they can overcome that resistant mutations that are developing with some of the covalent BTK inhibitors. This is a study, and again, don't follow up on all the, I apologize, I'm showing some data. I know that's a problem. But the point being is this was the study that led led to the approval in the US of this drug called Pirtobrutinib. This is the Bruin study that we participated in. And here, these are all the patients had gotten a covalent BTK inhibitor. So they were already treated with a Brutinib or a Calibrutinib or Zanubrutinib. And the fact is then, so that many of them had developed a resistant mutation to these BTK inhibitors. And the fact is that Pirtobrutinib was able to have them re-respond and work despite the fact that they had a mutation. And so that's where this drug got approved. So this is an important drug that you're gonna see. Now, it is also a pill and it's given chronically right now, but that's gonna change too. And this is just some of the curves showing that in these very heavily pretreated patients that it stopped the disease from progressing. And so people were able to take this drug for years and stay on the therapy, okay? Now, this trial was very heavily pretreated patients. So it's not gonna last forever on these individuals, which is why we always gotta think about more therapies, but it did allow these patients to re-respond to this type of therapy. And so that's why this study is what led to the approval in the US and hopefully soon here in Canada. But like many, we do want people to try to get off therapy. So you're gonna see there are gonna be many trials, and this is just one that got presented at our meeting recently in December, is that there are many trials that are also looking at combining, just like they did a Brutinib and Venetoclax and a Calibrutinib and Venetoclax. There are many studies that are looking at Pirtobrutinib in combination with Venetoclax to see, can we get people off of drug as well? So you'll see lots of trials looking at, Pirtobrutinib with Ven or with plus or minus an antibody, trying to get people to also make a time-limited therapy with Pirtobrutinib as the first non-covalent BTK inhibitor. It's not the only non-covalent BTK inhibitor that's being evaluated. There are many, and I can't touch upon all the drugs, but this is another drug called Nemtabrutinib, which is also another non-covalent BTK inhibitor that's showing nice responses in very heavily pretreated CLL patients. So just to let you know, so these are drugs designed to work around the resistant mutations that people may develop if they're on one of these covalent BTK inhibitors. Now, we actually have some cool other agents that are being developed. This is called Rockbrutinib, and this actually does both. It can bind tightly to C481, to the BTK site that the covalent BTK inhibitors, but it could also get around the resistant mutation. So it does both. It's a dual BTK inhibitor. And so there's some exciting data that's being presented in the last couple of years about some of these agents that have both mechanisms of actions, and so you'll see some of this. Again, these are really early studies, but I'm just highlighting some of the key, some of the clinical trials and key drugs that are evolving as we look at new agents for you all and how they go from clinical trial eventually, hopefully, for some of these into actual approvals. And this got presented 2 years ago, and this is the update that we did at the meeting, showing that some of these patients, it really can hold their disease at bay and stabilize their disease. So stay tuned for more about dual inhibitors as well. Now, what about BTK degraders? My colleagues mentioned this earlier, and this is a totally different way of binding to BTK. We talked about the light switch. We talked about how covalent BTK inhibitors can bind and prevent it. We talked about how the non-covalent BTK inhibitors can get around if there's resistance that develops and the light switch changes. But what about removing the light switch altogether? Removing it and having it completely put in the recycle bin, and so it's not there, so then the CLL cells can't survive. That's where BTK degraders come in. And there are several that are in development, and I'm just really gonna, just highlighting the fact that there are many compounds that are being done in clinical trials to look at BTK degraders. These are also a pill, just so you know. And some of these trials are looking at right now in single agents. Some of them are we're gonna start looking at them in combination with other drugs. But certainly this can also has a potential to overcome some of these resistant mutations that patients can develop, whether they get a covalent BTK inhibitor or a non-covalent BTK inhibitor. And just to highlight some of this data, this is one of the drugs from Beijing, which I guess changed its name, so I think they're called B1 now. But this is the Beijing compound that's showing that they have some nice responses. And again, think about when we run a clinical trial, we start new drugs in patients who have exhausted or gotten lots of other therapies. So you're always going to see these small little pilot trials in patients that have multiple therapies for their CLL. The drug usually starts in the relapse setting, and then if it's good, it eventually moves its way up, okay? So that's where it starts, just so you know. So these are small pilot studies looking at patients who may have had 10 lines of prior treatment. You could see the range from 2 to 10. So just keep that in mind when we think about that. And this is the Nurex compound, so a different company looking at a BTK degrader, which also looks very promising. So keep that. That's a new sort of target to try to overcome the resistant mutations that can develop in the fashion that I just showed you with BTK inhibitors. Okay. Now, CAR-T. Wow, we could spend a half hour talking about CAR-T. CAR-T has come a long way. This started, actually CAR-T cell therapy is obviously not new at all. It actually started in acute leukemia, in ALL and CLL actually, many moons ago. And just unfortunately in CLL, the differences about CAR-T is you're trying to spurn on your immune system to attack your CLL cells. And with that, there were some very notable side effects with CAR-T in the beginning of its development. Some were neurologic toxicities, and some had to do with releasing cytokines that can cause fever and low blood pressure and all sorts of other side effects that could potentially make people very, very ill. It took a long time for CAR-T, despite these issues, to get approved in CLL, and actually its approval was only last year, despite it being approved for lots of other disease sets, right? So it got approved in acute leukemia for acute lymphoblastic leukemia, and approved actually in some lymphomas, so like diffuse large cell lymphoma. And so now, I think in CLL, one of the issues became the fact is, unfortunately, despite some of these side effects, I think one of the reasons that delayed its approval in CLL is all of these other therapies also became available too. And so it became, we had all these targeted therapies with less toxicity, and we knew about the toxicity of the CAR T cells, and it needed a little time. As CAR T cells have been used in a lot of different disease states, we've been able to sort of mitigate or help with, making some of these toxicities a little bit easier. The transplant teams or the immunotherapy guys who may give CAR T cell have gotten really good at mitigating for some of the side effects. And certainly it needed a little bit more maturity in CLL because the data, it wasn't as good as what we have compared to some of the common drugs we just talked about. So it took a little time for CAR-T to get approved in CLL, and yet not yet approved in Canada. But we're going to talk just a little bit about the data because I still think it's relevant. What CAR T cell is essentially we take your cells out of your body and we manipulate them in the lab with a virus typically to recognize your CLL cells. And they grow them in the lab because you need a certain number of these cells to do their job. And then you actually do get a little bit of chemotherapy before you get the CAR T cells, before it actually gets infused. So it's not chemo-free, but it's just a dose of that, and then the T cell, and that helps with reducing the disease burden of the CLL burden in a patient, so these CAR T cells can do their thing when they're infused, and then hopefully when they're infused, they're going to go and attack the rest of your CLL cells. So it is a process, and it does take a little time to make. Now, again, that time period is shortened as the companies and manufacturers are getting better at doing this, but it does take a little time. So this is the study that led to the approval in the US. It was called the Transcend study. And so essentially, as I said, patients got their cells taken. If they had disease, so let's say, because it takes a little time to manufacture your cells, if you needed some therapy, you were able to get some bridging therapy during that time period. Then you got some chemotherapy, that's called the lymphodepletion prior to the CAR T cell, and then you got your CAR T cells. Now, what's important about CAR T and CLL, which is probably another reason why it didn't get approved so quickly, is that really what we know is that for most of the patients who go on this type of study, these were patients who were multiply relapsed. And so that is important to keep that in mind as well. What we also know for CAR T is that if we can get patients to have a really good response, that's the green curve. So if you get a complete response to CAR T, it's durable. And so that's, I think, a big focus for CAR T, for the folks who do CAR T cell, is we're trying to improve upon the complete responses so that we can make CAR T more durable for CLL patients. Because for other therapies, we just talked about the BTK inhibitors, you don't need a complete response to do well. You'll still have disease. Everybody's just mentioned the reason why you take a BTK inhibitor chronically is because it suppresses the disease. You'll still have disease in your bone marrow, so you're not in a complete response, but your blood counts may be normal, your lymph nodes are gone. You could be on a BTK inhibitor for years. You don't have to have a complete response. But for CAR T, it's important. So, I think what we're trying to do is try to optimize this therapy for patients with CLL. We're trying to figure out who might be the best patients to undergo this type of therapy, knowing that there are still some potential side effects. But it potentially could be really important therapy for patients who are multiply relapsed or who have aggressive disease. So it's still a modality. I like to think of CAR T as just a different modality of trying to obviously spurn on your immune system to attack your CLL cells. And so it's still an important modality potentially for some patients to have available. Now, what the most recently at our meeting at ASH, what became important too is we're actually, as I said, trying to improve upon that complete response rate to see if the CAR T cells will be more durable. And so this actually used ibrutinib in combination with the CAR T cells. And for this was just presented a couple months ago, it doubled the complete response rate from 20% to now in the 40%. So we're still learning, CAR T cells still evolving, and hopefully we can make this better for patients. Now, I think partly it also depends on all the other approvals of other drugs that happen, because as I said, CAR T cells sort of gotten relegated down here just because of all these other drugs we have for CLL patients. And as someone alluded to, I think you did, saying, I don't use allo transplant, or did you, Alina? Somebody says, I don't use transplant that much anymore for CLL patients. CAR T has been really relegated down here just because of all these other great therapies that have come about. But hopefully we can modify this therapy for patients who might need this and make it better. We'll see. We'll see where this fits in with the whole other grand scheme of therapies that are for CLL. Okay. Now, what about newer BCL2 inhibitors? So we heard a lot about venetoclax. And BCL2 is overexpressed in CLL. So think of it like a life vest that helps the CLL cells survive. And you know, one analogy is that venetoclax does a really good job at mopping up the disease and poking holes in the life vest and allowing these cells to die. Maybe the next generation BCL2 inhibitors might do a better job. We don't know that yet, but certainly there are newer ones, and we're going to see whether or not they improve upon venetoclax or not. So one of these agents is a drug called Sonrotoclax, and so this is being looked at both as a single agent, but also now in combination, giving all these combinations that you just heard about with venetoclax and a BTK inhibitor. Similarly, Sonrotoclax is being combined with BTK inhibitors like zanubrutinib. And so very exciting results that we're seeing, some very high responses, and this is a clinical trial that's running in the frontline setting with this second-generation BCL2 inhibitor, Sonrotoclax plus zanubrutinib. And so very, very high responses. So we'll see how that goes. And then we have another BCL2 inhibitor called Lisaftoclax. And one of the things that came up earlier about venetoclax is this sort of lengthy ramp-up period, and many of you might know this or have been through this, where we have to watch, because of that tumor lysis and all those electrolyte imbalances and kidney disorder issues that we have to watch for. The question is, will these newer BCL2 inhibitors be easier to use? Can they shorten that ramp-up period instead of every week for 5 weeks? Can they do a shorter ramp up and not have so much, electrolyte imbalances? And so this drug is looking at that strategy where they're actually ramping up the dose every day and not seeing the same sort of electrolyte imbalance issues. So they may be able to shorten this time period and make the drug more user-friendly, so to speak. And so there are clinical trials looking at this drug as well in combination with rituximab or in combination with acalabrutinib. And so there was some data presented with the combination of this BCL2 inhibitor, Lisaftoclax and acalabrutinib. So stay tuned about more information about some of these newer generation BCL2 inhibitors. Just like we had the next generation of the BTK inhibitors after ibrutinib, you got acalabrutinib and zanubrutinib. Now you have some newer generations of BCL2 inhibitors that are following in the footsteps of venetoclax. So stay tuned for more data about that. Okay. And then I want to speak a little bit about bispecific monoclonal antibodies. And so you heard some, monoclonal antibodies have also been around for CLL for a very prolonged period of time. Rituximab and obinutuzumab, which were mentioned previously, are great drugs. They target a protein called CD20 on your CLL cells, and they help kill the CLL cells that way. Well, now we have antibodies that can target not only your CLL, but also attach to your T cells and sort of bring your T cells in close proximity to kill off your B cells. And so these are called bispecific monoclonal antibodies instead of just a monoclonal antibody like rituximab or obinutuzumab. And there are many of these that are in development as well. And some of them are already approved, not for CLL, but are approved for lymphoma. Are they approved here in Canada? Okay, sorry. You said no, you said yes. What are you going to do? Not CLL, but for other lymphomas, yes? Okay. So in the US, similarly, they're not approved for CLL, but they're approved for some lymphomas already. So they've shown really good activity in lymphomas, and now they're being evaluated for CLL. And so one of these drugs is named Epcoritamab. There's another one, mosunetuzumab. And so again, targeting both your B cell and using, in proximity and bringing your T cells to kill off your B cells. And in CLL, we have trials that are also looking at this agent in higher risk individuals and individuals who have Richter syndrome, right? So their disease might have changed to a lymphoma or a more aggressive lymphoma. And since it's been approved in lymphoma, that would make more sense, right? So it knows that there may be some activity in patients who transform from CLL to a large cell lymphoma. So initially we had some data and some presentations with Epcoritamab in patients with Richters, but we also have data in CLL. And the responses in CLL are quite surprising to us as a monoclonal antibody. And I'm just showing this because it's when we first saw this data, we were all a little bit taken aback because when we look at rituximab and obinutuzumab, great monoclonal antibodies, but we usually don't see this kind of response. And so this was quite high responses in very heavily treated CLL. Now, the difference in some of the toxicity, though, of the bispecifics, however, you heard a lot about toxicities of all these drugs, of the BTK inhibitors and venetoclax. What's interesting is this mimics, because remember, it brings your T cells in proximity to your B cells, it mimics a little bit of the toxicity of CAR T cell. That stuff I was talking about with the cytokine release syndrome and some of the neurotoxicity does play a role a little bit with these bispecifics. And so, the question is, they're more mild, but it's something we have to, evaluate patients for and keep a close eye on them. So actually, the way we give this drug is this is given usually by injection or sub-Q injection, but the dose also gets stepped up. And it starts as an outpatient, but when you get to the first full dose, believe it or not, we admit patients for the first full dose of this drug to monitor for the cytokine release syndrome and for neurotoxicity that we can see with CAR T cell. So it's very predictable at the full dose. And so then if they tolerate that fine, then they get discharged, and then they'll continue on the full dose of the drug as an outpatient. But certainly it's something that we do have to monitor with the bispecifics, is that you do need to monitor for similar side effects that you do for CAR T. It's just not as intense as CAR T, so keep that in mind. And probably when we start, there are trials that are combining this drug with other agents, there are probably ways to mitigate for that side effect as well. And this was presented recently at one of our meetings, showing that you can maybe mitigate for some of these side effects by adding additional lower doses in before you get to the full dose to try to lessen the chances of this happening. So this is another exciting tool that we have that is undergoing development in clinical trial, whether as a monotherapy or in combination with other therapies and in Richters, that this is yet another, I think, another important tool that we will see move forward in CLL as well. See? So with the little cartoons and some time to spare for questions, you see, I told you I would catch you up real quick. There's lots of new therapies evolving, and I really just wanted to highlight that, is that I think you've heard a lot. We're hoping that as we can improve upon the therapies and obviously, prolong, you saw some slides earlier that really showed that the survival of CLL patients continues to improve. And all this is due to newer agents and newer therapies, understanding the biology of the disease and moving the field forward. So it's really been phenomenal for some of us in this room who are older, I didn't say old, but older, who have done clinical trials for 20 years, okay? We've really moved the field forward, and it's been a phenomenal, for me to be a part of some of this has been just a phenomenal thing to be and to impact patients' lives and bring you all and move and have you guys do better and better. We're not done yet. By any means, we're not done yet. We have to improve the quality of life and decrease toxicities of these therapies, but certainly we're doing better. And there's lots of new agents coming down the pike that will hopefully impact all of you if needed, if you need it, in the future, that hopefully we can improve upon the survival even further with CLL. So with that, I will end up and say lots of new therapies in the pipeline. Hopefully you'll have some more approvals in Canada, particularly with the non-covalent BTK inhibitors, which I think Pirtobrutinib is on the docket hopefully later this year. CAR T, I don't know. I don't know where that sits in Canada, so I'll leave that one alone. But lots of new drugs that are coming down the pipe, and clinical trials are definitely helping us get further along in CLL, and the field's moving much quickly. So with that, I will end and answer any questions. Thank you.
Again, yet another really fantastic talk and overview of what's to come. While you guys are doing your workshops this afternoon, I think I'm going to see if Nicole can bring the speakers and do a little PowerPoint workshop. All those cartoons were amazing, especially the life jacket on your T cells. That was awesome. We will take a couple of questions, I think, before lunch, if there are any. I know this is a rapidly evolving area, and I appreciate a lot of terms and terminology that you may not be as familiar with.
Doesn't have to be about new therapies.
Yeah, it could be about anything.
Any questions?
Is there one?
Oh, there's one.
Yeah, a couple in the back there. And okay, we're good. We're rolling now.
We're rolling now.
Okay, she handed me the mic, so I guess just a quick question related to the new therapies. How do they line up against first-line treatment and second-line treatment and third-line treatment? I didn't know where they fit in the context of that.
Yeah, so right, we talked, it really does depend on your journey. I mean, obviously these other therapies are going to be relegated first to patients who have had probably a lot of these other therapies, right? So if you've had BTK inhibitors and venetoclax or a BCL2 inhibitor or combinations, these are going to be relegated right now to the relapse setting, so multiple relapse setting, until approvals move that up. If they do well, then usually when these drugs start, right? Remember I said they kind of start in the multiply relapse setting. If things do well, they may move up, or they may get starting. Maybe we see some data that these newer agents look good in combination with other agents, and then they slowly get moved up. And then you see these clinical trials where they're randomized, right? So they might get a newer therapy or a combination of a newer therapy versus an older treatment. So then there might be some combination, there might be some trials then we'll do a randomized study, and so you get Epcoritamab and venetoclax versus a newer therapy, and then we see, is that better than the newer therapy or not? But this is going to take years. So most of these newer approvals of some of these agents, like Pirtobrutinib, which might be approved later in Canada this year, will still relegate it to after patients have these other therapies first. Until we've really proven that it's worked in that setting and doing well, and then maybe it'll slowly move up based on other clinical trials that evolve over time. So that's, unfortunately, the way that some of this works depends on where these drugs first became available and got approved, but certainly they may move their way up closer to frontline if they look really good, or look like they may even be more promising compared to some of the current standards of care, which is why you see that chemotherapy has now fallen out of favor a little bit, right? So it takes us a while to do this and move it frontline when we see toxicity and safety data and efficacy data that does take more time in CLL to prove. So it takes a while to get there. There was someone.
Hi. Thank you again for making it comfortable for us to ask these basic questions too in the stages that we're all in. And so I had asked another panelist about this, and I wanted your opinion. So being in the untreated, wait and see stage, which is interesting because as patients you hear, well, there's nothing we can do right now. It's just wait and see. And you're sitting here going, I got a diagnosis, my husband's diagnosis of CLL. What do you mean there's nothing I can do right now? And so I have a question regarding immunotherapy without the chemo. And I was just curious on two things. One, if it's an autoimmune or if your immune system is low, having CLL, is it beneficial then to try to raise up your immune system naturally using immunotherapy treatment now to try to build up your own natural antibodies to fight this, or maybe not make it worse? I know you can't reverse it, but to prevent it from going to different stages. And two, the second part is, are there as many studies as there are regarding the drugs and pharma regarding that immunotherapy only treatment, and how has that improved anyone with CLL?
Yeah, so these are very good and complicated questions. First is for those who, and I know this is hard, we were talking about this earlier, For those who are recently diagnosed and are on, I hate watch and worry, can we just get rid of that and do the active surveillance is so much better. For those recently diagnosed, there's no doubt that to say that I have a new cancer, and that's why I love my commentary by my colleagues, where we really need to switch this to thinking about this disease differently as a true chronic disease, because otherwise most people go, well, I have cancer, and no other cancers, well, maybe with the exception of prostate cancer, which is also can be monitored for individuals, but many cancers, we don't sit and watch, right? We deal with them right away. We're trying to get rid of it. We're trying for it to not spread or go anywhere else when we think about other cancers like solid tumor cancers. But for this, it can play a mind game for a while, particularly the first year or two after you're diagnosed. And so it can play some head games. It's going to take a while. It truly is a chronic disease. But the advantage of being in the, and I'll get to your questions, I promise. The advantage of being in the active surveillance group is that you see how things are evolving. And it may change. And so you get to watch on the sidelines as the field evolves and grows and changes, and new therapies may change, and older therapies may go out, and you may not need exposure to other therapies. So for those on active monitoring and surveillance, it's an important group where you guys can learn and see what's going on in the field, and some therapies may move and change, and survival continues to improve. So just think of it that way. I know that's not a perfect answer, because it's not, because we don't have curative therapy, but if I put somebody on therapy who doesn't need therapy, I might be starting a clock of resistance. And we don't want to do that either, right? So if you really, Alessandra showed very nice curves that there haven't been any studies yet that have showed that early therapy is beneficial. And so if we start the clock, your CLL cells might become resistant to therapies, and then we might lose those therapies down the line. So unless we have therapies that change that, then we could reevaluate that. But right now, we don't want to expose you if you don't need treatment, you're otherwise doing okay. So keep that in mind. So it's important to be in the active observation. Now, with regards to your other questions, immune therapy, all therapies, unfortunately, no matter what the therapy is, with differences in chemotherapy, targeted therapies, and CAR T-cell therapy, they also do, in the short term, do reduce your immunity too. And so, the goal is hopefully if you treat your CLL that's active and causing you to have issues, that you can right your immune system if you better your CLL, meaning if you put your CLL into remission, that eventually your immune system will get better as well. We don't have any data yet from CAR T-cell, which is what I think you mean by immune therapy. Is that correct? I just want to make sure. So we don't have any data that shows yet that, because all these studies are done in the heavily relapsed refractory group, that yet moving up, doing CAR T-cell earlier will have a benefit yet on CLL patients. Doesn't mean it couldn't. It's just the way that these have evolved in sort of the way in the relapse setting. There are some large cell lymphoma studies that have moved up or are moving up immune therapy earlier, in earlier lines of therapy, and we might learn some about how somebody's immune system is from those earlier studies, a different disease, but from some earlier those studies in CAR T in large cell lymphoma, for example, that if they get it in front line versus second line versus later. But right now, it's still relegated to the relapse setting. So we don't know that treating, using immune therapy now earlier up front and you would improve the immune system enough for your CLL, I guess right now. I mean, the data is not good enough to say we'd move CAR T in front line anyway, so we wouldn't do that. I don't know if that quite really answers your question, but in the short term, there's no doubt that, CLL is hard because your immune system is impacted not just by your CLL cells, but other cells in the microenvironment. And so we know that treatments, and many of you might be on treatments short term, we know that some of the side effects we talked about, including infections because your immune system is down, it doesn't mean they go away if you're on these therapies either, right? So some of you may still be plagued by infectious complications even when getting these therapies or even shortly after you get off of these therapies. We hope that by getting your disease in a good quality remission, whether you're taking a chronic BTK or you get a venetoclax-based combination and you get off therapy, by improving and getting rid of your disease or controlling your disease, that your immune system gets better. But we do know that there are some patients that, despite them getting good responses to therapy, may still always be plagued with some immune dysfunction and increased infectious complications. And so it's still important to make sure that you tell your doctor, regardless of where you are, that if you're having infections and things like that, so they know, because that could still be related to your poor immune system despite the fact that you're doing well on therapy, okay? So your question's actually really quite deeper than you probably even imagined, and much more complicated. But we're not yet moving up a CAR T cell yet in CLL because of some of that data that I showed you. Okay. Anybody else have a question?
Do you have time for one more?
We can take one more, sure.
So my only objective really for coming to this conference was to have some hope, and I have hope and excitement, so I'm not trying to derail that, but I'm also realistic, and I know that we live, most of us here, in a publicly funded system, and we rely on government funding, and you are a close neighbor, and we rely heavily, as you see, our drug approvals typically follow your drug approvals, and so a lot of the development and the studying is happening south of the border. We're also seeing that there's been a dismantling of institutions and departments and canceling of funding that we're learning about in cancer research. So I'm looking for some reassurance that what's in the pipeline is going to continue to move forward during these uncertain times.
Fair enough. I think we probably all echo your comments, especially since I'm from Columbia. Did I say that? I think we all echo your concerns. There's no doubt that we're all concerned about what's going on, south of the border or not, with funding. Thankfully, I think that, we have a lot of partners and advocacy across the board, that despite some of this, I'm hoping that what you're hearing in the news will be tempered over time. And so let's hope, right? Yeah. So, and a lot of the industry, part of this is a lot of industry-based too, and so, although I can't say that they can't get impacted by this, but I think that most of us, the partnerships that we've evolved, that we're all pretty optimistic that we'll continue the clinical trials that we're doing. Yes, I do think depending upon where your money is coming from, there might be some things that get curtailed. Or we need to be more fiscally responsible. And you guys are really good, actually Canada's a really good example about that. So, I know that you mentioned about the fact that south of the border, maybe we have access to certain drugs sooner, some. But, I do think that sometimes we're not really fiscally responsive south of the border. And that's not always beneficial to the future. So there may be ways I am optimistic that we can still continue our research endeavors with what's going on. Despite what's going on, I should say. But we might have to be a little bit more thoughtful about some of the trials that we do. And I think that maybe that's not always a bad thing. So, and I'm not going to go into more details about that, but I think that there are some, I think we have to be a little bit more picking and choosing about certain clinical trials, and maybe we do have to be more fiscally responsible with that, knowing the potential uncertainty that we have. But I think we're still going to move forward. I'm optimistic, put it that way.
I think with that we should probably break for lunch. It seems like the appropriate thing to do. No, those are, again, very excellent questions. These are important discussions. Thanks so much for your engagement this morning. I think it's been an excellent morning of learning and presentations for all of us.